Now we proceed to pathological changes in OCT in macular diseases by Dr. Indu. She is the consultant. She is consultant in vitreoretina at Chaitanya Eye Hospital and Research Institute, Kottayam. On to.
Good morning, everyone. So Dr. Dhanya has very nicely explained the OCT in a normal retina. Now I'll be discussing on pathological changes in OCT in macular diseases. So retinal pathology in OCT, the interpretation depends on two things: how much light is reflected and how much light is transmitted or blocked. There will be a little bit of repetition from the previous presentation. So how much light is reflected is called as reflectivity, and reflectivity can be a hyporeflective or a hyperreflective. Hyperreflectivity indicates that it reflects less light than surrounding tissues and it appears black in color. It is mostly indicative of a clear fluid. This fluid can be seen in the retina, intraretinal, subretinal or sub-RPE space. Hyperreflectivity means it reflects more light than surrounding tissues and appears white. It indicates mostly solid lesions and even turbid fluid. So it could be due to hard exudates, calcification, pigments, fibrosis, preretinal or subretinal membranes, anything solid or turbid. Now, how much light is blocked or transmitted causes shadowing or reverse shadowing. So if a lesion absorbs all the light that falls on it, it causes hyporeflectivity posterior to it, and that is called as shadowing. And if there is thinning, it allows more light than normal to pass through it, and it causes hyperreflectivity posterior to it, and that is called as reverse shadowing. So reverse shadowing indicates thinning. Now coming to analysis of an OCT pathology, as Dr. Dhanya said, it has to be gone in a very systematic manner. First you look at the retinal profile, then the fovea, and then a layer by layer analysis. So retinal profile, it can be abnormally concave or abnormally convex, abnormally thickened or abnormally thinned out. A retinal profile which is more concave than normal, it indicates usually a posterior staphyloma in high myopia, whereas abnormal convexity indicates tumors, scars, or even a dome-shaped macula. So retinal profile gives a clue to a diagnosis. So if you find an abnormal concavity with a subretinal membrane, that indicates it is a myopic CNVM. Abnormal convexity with a little amount of fluid on the top might be due to dome-shaped maculopathy. If you see an abnormal convexity with choroidal folds, might indicate a posterior scleritis. Now coming to thickness, you can have thickening or thinning of the retina. It can be localized or generalized. A generalized thinning indicates usually ischemia, as in case of an occlusion, whereas localized patchy thinning might indicate a age-related degeneration or a central serous retinopathy. And focal thickening can be due to localized edema or focal traction, whereas generalized thickening is usually due to preretinal membranes causing a very broad traction on the macula. And after that, you go to the foveal contour. So normal foveal contour can be blunted or you can have defects. A blunted foveal contour with severe visual abnormalities is usually seen in foveal hypoplasia. So here you can see there is complete absence of foveal depression, and it is commonly seen in hereditary disorders like albinism or aniridia. Whereas if you just see a blunted foveal contour without any significant visual abnormalities, it is called as fovea plana. It is normal. Now coming to defects at fovea, you can have full thickness defects, and that is called as a full thickness macular hole when there is total absence of all the neuroretinal layers. Whereas if the defect is partial and only involves the inner retina without involving the outer retina, that is called as a lamellar hole. There are two types: a traction one, which is associated with an ERM around it, which causes traction, tangential traction, and causing inner retinal layer splitting, as you see here. Whereas the other one is called as a degenerative LMH, when you see degeneration of the layers, which is causing the lamellar defect. Now coming to layer by layer analysis, so you go from anterior to posterior. So in the vitreous you can see a few abnormalities in the vitreous itself. Like for example, you can see a membrane which is attached to fovea, which is the vitreous membrane. A silicon oil reflex on the right side. You can see dot-like opacities which could be astroids, hemorrhage or wheat cells, and even an operculum overlying a full thickness macular hole. Then you go to the vitreoretinal interface. So in vitreoretinal interface, three things are the common ones. One is the preretinal membranes, most commonly vascular membranes, causing a very broad traction. You can see the traction of the disc also. The other one is an idiopathic membrane. You can see just a small membrane over the macular region, or you can see that the vitreous is causing a vitreous membrane which is causing a focal traction of the fovea, which is called as vitreomacular traction. So preretinal membranes are usually proliferative membranes. They are very broad. They cause a very significant traction which can cause retinal layer changes and even submacular detachment. In VMA, you find that the vitreous is attached at the fovea alone, but it is not causing any anatomical changes. That is called as vitreomacular adhesion. But sometimes it causes traction on the central part. You can see a small tenting at the fovea. You can see pseudocyst at the fovea. You can see inner layer schisis in the fovea and even a submacular detachment. And that is called as vitreomacular traction. Now coming to idiopathic membranes are seen as a thin hyperreflective membrane over the macula. If it is not causing any change in the foveal contour, it's grade 1. If it is causing slight flattening of foveal contour, it's grade 2. If it is causing an ectopic inner foveal layers to migrate to the center, that is called as stage 3. And stage 4, when you find that there is total disorganization at the fovea. Now sometimes you can have a tangential contraction of the fovea which causes steepening of the foveal contour, and that is called as a pseudohole. Pseudohole appears like a hole, but it is not a hole. And usually vision is not much affected in such cases. Sometimes what happens is that the ERM contracts and the fovea gets pushed out through the opening, and this is called as foveal herniation. That is also sometimes seen with an epiretinal membrane. Now coming to inner layers, you can have 3 important problems. One is hypo, hyper and disorganization. Hyporeflective can be due to cystoid edema when it is more round in shape, inner retinal schisis which is more column-like, or a moth-eaten appearance. You see cavitations which are seen in macular telangiectasia. And inner layer hyperreflectivity due to something deposited there, solid lesions. It could be hemorrhage, it could be pigments, or sometimes when you see the last picture, you see there is a diffuse inner layer hyperreflectivity which indicates hypoxia, as in case of a CRAO. And you can have a complete disorganization of inner retinal layers which is called drill, and drill is commonly seen in DME and RVOs, and it indicates significant ischemia. Now coming to outer retina, 2 important things that you have to look for, that the bands and deposits. In the outer retinal bands that you have to see are the external limiting membrane as well as the ellipsoid layer. It could be intact, it could be disrupted. So disruption is commonly seen in mactal, CSR, post-trauma cases. And sometimes you can have a diffuse thickening of the ISOS junction which can be seen in Berlin's edema. And deposits are usually outer retinal tubulations which will have a hyporeflective center with hyperreflective borders. Should not be mistaken for intraretinal cysts, and they are associated with subretinal fibrosis. Now coming to so you have finished the retina, now you go to the subretinal space. So again in the subretinal space you have 2 important lesions, hypo, hyper. Hypo usually indicates clear fluid, commonly seen with CSR or sometimes along with the neovascular membranes. Hyperreflective indicates again a turbid fluid which might be a fibrin CSR. You can have deposits, vitelliform deposits, or you can have a thick membrane in the subretinal space. This along with intraretinal fluid or subretinal fluid. And after you finish the subretinal space, you go to the RPE. So RPE can be elevated with a clear space underneath which indicates a serous PED. But if there is something deposited there or a hyperreflective material underneath, it indicates more severe problems. It could be due to drusen. It could be sub-RPE blood. Sub-RPE blood causes shadowing posteriorly. You cannot see anything behind it. It could be a sub-RPE membrane. Membranes can have associated shrum and associated fluid. Or you can see sub-RPE polyps, which are actually hyperreflective material under a thumb-shaped polyp or a notched PED. And RPE could be diffusely thickened as in case of a scar, in which case you will see a lot of intraretinal changes above it, or it could be generally thinned out as in case of a geographic atrophy. And then you go to the choroid. Choroid can be measured into the EDI. You can see all 3 layers of the choroid. And in the choroid you have to assess the thickening and the thinning. Thicken in case of pachychoroid diseases, inflammatory lesions and tumors. And thinning can be seen in elderly and myopia. You can also make out a few abnormalities like a choroidal cleft or a choroidal fold. So the take-home message is you have to evaluate all the layers. You have to scroll through the raster and classify the abnormality accordingly. Thank you.